Hello, everyone, and welcome to the AFTD educational webinar, Brain Behavior Connections in Frontotemporal Degeneration. I'm Matt Sharp, AFTD's program manager, and on behalf of everyone here, thank you for joining us today. A few housekeeping items before I introduce our guest presenter. Please note our audience will be muted for the duration of the presentation. This helps to keep the background noise to a minimum so that everyone can hear the presenter clearly. If you have any technical issues, please write a message in the questions box and AFTD's Lauren Gauthier will try to address them with you. There will be time for Q&A at the end of the presentation. Again, please type your questions in this box as you think of them, and we will address them as many as time permits. This webinar will be recorded and archived on our YouTube page with all of our other educational webinars. You can visit youtube.com/theaftd.org to find our webinar playlist. I'd also like to let you know about some upcoming events that you may be interested in, all of which are virtual. On February 27th, the Penn FTD Center will be presenting a conference on education and support for familial FTD and ALS, entitled Fighting for the Future. AFTD is a co-sponsor of this online event. Visit ftd.med.upenn.edu for more information. On March 5th, AFTD will host an externally led patient-focused drug development meeting. This is a unique opportunity to make your voice heard and educate representatives of the U.S. Food and Drug Administration about the FTD experience. People with FTD and anyone whose life has been personally affected by the disease are encouraged to participate live in this virtual meeting via polls, chat, and phone-in. Visit the AFTD website for more information and register at theaftd.org/pfdd. Finally, AFTD will hold our annual education conference on May 13th and 14th, also an all-virtual event. Registration will be open in March, so stay tuned to the AFTD website for more information. Next slide. At this point, I would like to introduce our guest presenter. Lauren Massimo, PhD, is an assistant professor at the University of Pennsylvania in the School of Nursing and the School of Medicine, Frontotemporal Degeneration Center. Dr. Massimo's research program focuses on identifying the cognitive and neural basis for symptoms of neurodegenerative disease. Over her decade-long career as a nurse practitioner in cognitive neurology, she has enjoyed the opportunity to work with and support many patients with neurodegenerative disease and their families. She is a graduate of the PhD program at the University of Pennsylvania and is currently funded by the National Institute on Aging for her work on cognitive reserve in young onset dementia. Welcome, Dr. Massimo. We are very glad you're here. And that I will turn things over to you.
Okay, great. Okay, great. Thank you so much, Matt, and thank you to the AFTD for inviting me to be here today to talk with you about brain behavior connections in frontotemporal degeneration. So here is my disclosure. And from there, I'm going to go on to some objectives. So here's an outline and the objectives for this webinar. I initially developed this lecture for an AFTD education conference, which took place a few years ago in Baltimore, where I was asked to help explain the biologic basis for behaviors that we see in FTD. And of course, I thought, well, you know, this is really interesting scientifically, but more importantly, I found this information was really helpful for caregivers to understand why behaviors occur. And it could help drive home the point that behaviors of the people with FTD aren't intentional, that these behaviors are often a direct result of the devastation of the disease and the dysfunction in the brain. And so the overall purpose of this webinar is to explore the brain and the functions of various structures in the brain that can help explain some of the behaviors that we see in people who have FTD. So the specific objectives that we'll cover, first, we're going to review the anatomy and the function of the brain with a specific focus on the frontal and the temporal lobes. Next, we'll review common behaviors that we see in individuals with FTD. You may find it challenging to explain behavior in your loved ones. So we're going to talk about the changes that we see in the brain and how these changes cause behaviors. And lastly, I'm going to talk about how we can use our understanding of brain behavior connections to provide tailored, non-pharmacological or non-medical interventions. So before we get into the anatomy, I want to start by talking about one of the reasons that I pursue this kind of work. I've always been interested in trying to understand the brain and how it ties to the way that we behave. And my PhD work focused on the neural basis of apathy. So my work was very biologic in nature, which is important, but my background is in nursing. And I wanted to have a better sense of what behaviors actually looked like on a day-to-day basis. I wanted to understand the human experience of these behaviors. So I got a chance to sit down and do some qualitative research with a few FTD caregivers. And I asked them about what it was like to live with a person experiencing such profound behavioral and personality changes. Because up until this point, the scientific literature was full of how scientists can operationalize and measure behaviors, but it really lacked a rich description of FTD behavior. So here's a quote from that published article that I'd like to share with you. He doesn't say goodbye, and he doesn't kiss anybody or hug anybody anymore, even with friends or family. If someone dies or is ill, he has no feeling. It's terrible. You want to tear your hair out. And this was really powerful for me to hear. What this caregiver was talking about is the loss of the ability for her loved one to be empathetic. That glue of the emotional connection between this couple had dissolved. Another thing that I learned from this study is that FTD caregivers faced additional demands relating to coping with the meanings of these behaviors. And in this next passage, in the same qualitative study that I conducted, in order to cope with her husband's behavioral symptoms, this particular caregiver talks about how she can separate the disease from the person, and she tries to reduce her interpretation of his behavior to the neuronal level. I've learned that it is the disease. I've got that it's not him. I can almost picture the neurons not being able to, connect. I can just see them physically. And it's this reinterpretation in some moments where you may feel like you want to tear your hair out. And it can help in some ways to think of the anatomy that's behind the behavior. It's the anatomy that's driving the behavior. So oftentimes in my own clinical practice, I will show pictures of the MRI of the person affected by FTD to say, here is the reason that this person is acting in a particular way. And so that's what I hope to do with you today, to walk you through various studies that have been performed in people with FTD that demonstrate the brain behavior connection. So before I dive into the anatomy, I want to offer a few caveats to this talk that I'd like for you to consider. First, I'm going to speak very generally about what's known about certain structures of the brain and how it relates to behavior, but everyone's anatomy is very different. To that end, the brain is an amazing organ, and in many cases, it's not just one isolated region that causes the behavior. It could be multiple brain regions that often talk to one another, that may be dysfunctional or disconnected, that are contributing to what we see. So many times it's not so easy to localize certain behaviors to a single structure. And while I'm going to primarily focus on behaviors that are included in the behavioral variant frontotemporal degeneration, or the bvFTD criteria as a framework for this talk, there are certainly overlap among FTD syndromes. For example, we often see compulsive behavior in individuals with semantic variant primary progressive aphasia. We can see impulse control problems in people with progressive supranuclear palsy. There can also be overlap among symptoms. Oftentimes we see patients who have disinhibited behavior and ritualistic behavior. And lastly, behaviors can change over time. For example, folks that we see who may be pretty disinhibited in the early stages of disease may become increasingly apathetic over time. So let's talk about cognition. Cognition is not just about memory. It's about knowing and thinking and learning and judging. And it's divided into cognitive domains. First, there's memory, right? And this is comprised of short-term memory, so what you just had for lunch or what you had for breakfast, and your long-term memory, like your wedding day, birthdays. Executive function is a higher order cognitive process that includes things like attention, your ability to stay focused on a task. Attention enables you to focus while mentally identifying and distinguishing non-relevant information. Executive function also involves things like planning and organizing and task switching, multitasking. And this is one of the domains that are disproportionately affected in people with FTD. And we're going to talk about how impairments in executive function can contribute to problems with behavior. Language involves things like listening and comprehension, speaking, reading, and writing. Praxis is translating an idea into action, and this ties in closely with visual spatial functioning, how you perceive objects in space, and your perception of spatial relationships. And lastly, social cognition is the recognition and regulation of emotions and appropriateness of behaviors. And we know that this is also a domain that is affected in people who have FTD. So let's now walk through a review of the brain anatomy. Let me first orient you. This is the front of the brain. This is the back of the brain. And here we're looking at the left side of the brain. And so the frontal lobe is really important for that higher order cognitive function called executive function that I just spoke about, that involves planning and organizing and making strategic decisions. Executive function is what allows you to do things like put together a grocery list and then shop for your food items efficiently. It also allows you to do things like balance your bank account without bouncing lots of checks. The frontal lobe is also really important for regulating emotions, making sound judgments and decisions. And we're going to spend a lot of time talking about how these impaired functions contribute to the behavior that we see. Now, generally speaking, your language functions are directed by the temporal lobes of the brain on the side of your head by your ear. This includes things like speaking and comprehension. So people with primary progressive aphasia or PPA can have damage in their temporal lobe. And this is different from Alzheimer's disease, which affects the temporal lobes of the brain and a specific area in the middle of the temporal lobe called the hippocampus, which is important for memory. In the parietal lobe, which sits up higher in the back of your brain, is important for visual spatial function. And this is how we interpret what our eyes see, knowing where our body is in space. And so this can be a problem in individuals with corticobasal degeneration, for example. So here's just another figure reiterating what I just went through on the previous slide. And for the purpose of the webinar, I'm really going to focus in on the frontal lobe. So the frontal lobe is highly specialized around certain functions. And there are two important regions in the frontal lobe called the orbital frontal cortex and the dorsolateral prefrontal cortex. So one of the most important functions of the frontal lobe is decision making. We have to make decisions all the time, from what we want to eat for lunch to if you're working as a stockbroker, how you're going to allocate money. Another important factor in our decision making is the value that we assign to information that's presented to us, whether we find it pleasing or rewarding, or whether it's associated with perhaps negative consequences. And our brain assigns a value through a particular part of the frontal lobe called the orbital frontal cortex. And this is the part of the brain that in the frontal lobe that sits right behind your eyes, hence the word orbit. So you're going to hear me talk a lot about the orbital frontal cortex because it's implicated in a variety of behaviors that we see in FTD. Another important part of the frontal lobe is the dorsolateral prefrontal cortex. This area talks to the orbital frontal cortex to assess the overall net value of the reward, and it can incorporate information about other alternative courses of actions. So if you think about an expensive item that you see at a store, for me it's shoes. I love a good pair of shoes, and the shoes might seem really appealing at first, and my orbital frontal cortex is firing saying buy the shoes, but maybe there's some credit card debt that I incurred as a result of the last pair of shoes that I bought. So my dorsolateral prefrontal cortex is chiming in, starts calculating the debt, and says, oh, Lauren, is it really worth it? Perhaps you want to go look at that budget rack. So you can imagine what could happen if we don't have these two processes to keep us in check. So scientists are really interested in understanding how the brain impacts behavior. Studying brains of individuals with neurodegenerative conditions like FTD can help us to understand why certain behaviors occur. The most common technique to study the brain, the structure of the brain, is through magnetic resonance imaging, or MRI. So I'm sure many of your loved ones have had an MRI. That is often a tool that we use to make the diagnosis of FTD. So an MRI contains powerful magnets which produce strong magnetic fields that allow us to visualize the structures of the brain in great detail and high resolution. And we can look at the brain from different views. We can take slices of the brain going from side to side in the sagittal plane. We can look at the brain going up and down in the axial plane. And then we can look at the brain from front to back in the coronal plane. And so here are a few examples of the overall pictures that we see in people with FTD. These are coronal slices through the brain, again, from the front to the back. In the top left, we see a picture of an individual with FTD. And here on the right, we see a healthy person without a neurological condition, which we call a control. And this picture is taken through the frontal lobe at about this slice right here. And if you compare these two pictures, you probably will notice this dark, there's lots of gray or dark areas when you compare it to the picture on the right-hand side. And this black space here is where there should be gray. There should be brain volume there. There should be brain tissue there. And this black space is the loss of neurons or the loss of brain cells. And this is what we call atrophy. On the bottom picture, this slice is taken through the temporal lobe of the brain. And we see here that there's, compared to the control on the right side, that there are these dark areas here, where again, we should see gray, we should see brain tissue. And this is the picture that we often see in people who have semantic variant primary progressive aphasia, and we know that these areas are important for language. So here again is just another overall MRI picture of an individual with FTD. Again, this is the front of the brain, and this is the back of the brain. Here we're looking at from the side. And again, you can look here, you can see all this black here where, and that it's quite disproportionate to the back of the brain. So I want to review the most common behavioral symptoms that we see in individuals with frontotemporal degeneration. These are the current criteria for behavioral variant frontotemporal degeneration that were developed by Dr. Ruskowski. But let me again say that there are a lot of overlap in behavioral symptoms between FTD phenotypes. For example, individuals with primary progressive aphasia, corticobasal degeneration, and progressive supranuclear palsy may also have these shared behavioral features. So to make a diagnosis of bvFTD, you have to have at least 3 of these boxes checked. And there are a range of possibilities here, from disinhibition to apathy. So I'm going to quickly go through each one. Behavioral disinhibition. These individuals frequently exhibit impulsivity. They can have no filter. They walk up to strangers on the street. They say inappropriate things. They may tell inappropriate jokes. We can see apathy or indifference. Patients can have no motivation to do things that they were interested in. They may sit around all day long and not want to engage in any activities at all. We can see loss of empathy or sympathy, where people can have really bad insight or self-awareness, so they see nothing wrong with their inappropriate behavior. They can appear to be very cold even to their loved ones. There can be stereotype behavior like repetitive movements like tapping or rubbing. Sometimes there are more complex ritualistic behaviors that may center around food, where people have to eat a certain food at a certain time of day. And lastly, the neuropsychological profile shows deficits in executive function with relative sparing of memory. And so for the remainder of the webinar, I'm going to go through each of these behaviors and talk about what we know about the neuroanatomy and how damage in certain areas of the brain can directly contribute to the behavior that we see in people with FTD. So first we'll start by talking about disinhibition. It is a term that we give that demonstrates a lack of restraint. For example, you may observe behavior that's socially inappropriate. There may be a loss of social manners or impulsive behavior, such as conversations that are often interrupted or taken out of turn. There may be other impulsive types of behavior like impulsive buying or shoplifting. And so here, one of the first studies that I did as a doctoral student where our lab sought to investigate the brain basis for disinhibition. I asked caregivers to rate their loved one's disinhibition on a scale that asks questions like, does your family member seem to act impulsively without thinking? Does your family member do or say things that are usually not said or done in public? Does your family member do things that are embarrassing to you or others? And I looked for a relationship between the scores on that questionnaire and a measurement of brain volume. And here we see a heat map, and these brighter yellow colors here reflect areas of atrophy, again, that brain tissue loss that is associated with disinhibition. And we see that most of the atrophy is in that area of the brain that sits right behind the eyes, that part of the brain called the orbital frontal cortex. And remember from one of the first slides, this part of the brain is really important for interpreting rewards, recognizing consequences that are associated with behavior. And so damage to this area may cause an affected individual to have difficulty interpreting the value of social information. Remember, the orbital frontal cortex is also involved in impulse control and emotion regulation. And so as this structure accumulates disease, behaviors become more and more disinhibited and more inappropriate. And social boundaries that exist and the social norms that guide our behavior are essentially non-existent. And so if you think about how this might play out, your loved one saying inappropriate things to neighbors or your strangers in the street or interrupting conversation and seeing that there's nothing wrong with any of this. These are examples of the social norms that are typically not followed by individuals with FTD. Loss of empathy tends to develop early in FTD and is often one of the most frustrating and sad behaviors for carers because it feels like their loved one just doesn't care. There is an indifference to loved ones, a loss of emotional warmth or even sympathy for what others may be experiencing, even when there are sad and tragic events like deaths in the family. So one of the ways that our lab studied empathy was that we showed individuals with FTD cartoons of different social scenarios, and we asked them what they would do in social dilemmas. And we showed the participants this cartoon first. You see here that this guy is hanging off the roof, and you see that his kid's on the ground watching him, and we asked the participant, the patient with FTD, we said, so what will happen next? And the participants are given 3 scenarios, and they're asked to choose the next likely event from 3 choices. So choice A, the wife comes and saves the day by getting the poor guy a ladder. A suboptimal choice, which is letting the guy climb to safety on his own. And then a socially inappropriate choice, standing there and pointing and laughing. And in this study, the most common answer for the FTD patients was C. They chose the most socially inappropriate choice. And so when my colleague, Dr. Paul Essinger, took those scores on that we call the cartoon prediction task and related them to the brain volume, again, to look for an association of those people that lost empathy and brain volume, we see that loss of empathy was related again to orbital frontal cortex and also to the temporal lobe, in the superior temporal lobe. So again, it's not surprising that in individuals, not only individuals with behavioral variant FTD can show reduced empathy, but oftentimes individuals with progressive supranuclear, with semantic variant primary progressive aphasia who have temporal lobe damage can also show reduced empathy. Another very nicely done study in 2016 by colleagues in Australia suggests that there may be 2 core components that contribute to poor empathy in FTD. First, there may be what we call cognitive components of empathy. That involves the process of mentalizing or understanding what other people may be thinking or feeling. the process of kind of putting yourself in other people's shoes. And we see here that this is related to medial frontal cortex, and again, orbital frontal cortex and temporal lobe. And then the second component that contributes to poor empathy is an affective component, which involves responding to the emotional needs, the emotional experience of others. And here we see, again, overlap in frontal regions, and also an area called the insula, which is important for processing feelings. So the problem with empathy in FTD is likely driven by the inability for individuals to understand, to share, and then to respond to the emotional experience of others. Compulsive behavior is performing the same act over and over again. Some common compulsive behaviors that we see are simple repetitive behaviors like hand rubbing, leg slapping, humming the same tune over and over again. Then there may be complex ritualistic behaviors like having to visit the same restaurant at the same time of day, ordering the same exact food. And we can also see complex ritualistic behaviors play out in frequent trips to the bathroom. And here's a study that was conducted in the Netherlands. Again, let me orient you. This is the front of the brain and this is the back of the brain. And here we see in a patient with severe compulsive behavior that there are significantly dark areas, these areas of atrophy in the temporal lobes. So again, some of your loved ones, especially those with primary progressive aphasia, may also exhibit compulsive behaviors. This brain region is implicated in response flexibility. So damage to this part of the brain in individuals may have difficulty suppressing their urge to perform an action. Hyperoral behavior can be quite common in individuals with FTD, and this can range from consuming large amounts of food or a tendency to prefer carbohydrates or sweets. For some patients, they may even eat inedible objects or forms of food that shouldn't be consumed, like pet food, for example. And in this study, individuals with FTD were presented with sandwiches, and researchers measured the amount of sandwiches that were consumed by the person, and they found that a particular area, again called the insula, was implicated in the overeaters. And the insula is an important area that facilitates communication between brain regions about taste and emotions. So in individuals with disease in this area, it's likely that the I'm full signal that you or I used to stop eating is diminished in individuals with FTD. And the last behavior I'm going to discuss is apathy. Apathy is often cited as one of the most common behavioral symptoms that are seen in FTD. And it's been described historically in a variety of ways, such as passivity, loss of interest, lack of spontaneity, loss of motivation. But it may be that there are distinct subtypes, and these certain subtypes of apathy may depend on different parts of the frontal lobe that are affected. And so when we studied the brain regions associated with apathy in an early study in 2009, we asked caregivers about the presence of apathy. So we just wanted the caregivers to rate whether apathy was present or not in their loved ones. And you can see here that apathy is just associated with this huge, very broad range of atrophy in the frontal lobe. It's covering this huge part. So we start to wonder if the frontal lobe is indeed organized around certain functions. Are there different mechanisms in the frontal lobe that contribute to apathy? And when we looked more closely with an experiment that was designed to study different symptoms that we see in apathetic patients, problems with initiation, problems with planning, and problems with motivation, we saw that there were partially distinct areas of the frontal lobe that were affected that were associated with these symptoms of apathy. And so now I'm going to tell you a little bit more about these symptoms of apathy that we see. First, we see reduced initiation, which is related to an area of the brain called the anterior cingulate. The anterior cingulate is a part of the brain that's important for initiating action. And so we believe that persons who are unable to initiate action become apathetic, oftentimes just sitting quietly in a room without speaking or talking, and they can do this for many, many hours. The second distinct symptom of apathy is related to the inability to plan. And this was related to atrophy in the dorsolateral prefrontal cortex here in green. Again, this is the region that's known to be important for executive function. And so we think that people can develop apathy when they're unable to plan and organize and structure their activities. And we live in a very busy and demanding world. We're expected to do lots and lots of things all at once. We're expected to multitask. And when activities are too complex, or we're having to juggle too many things at once, it can lead to apathy because people become overwhelmed. And lastly, we see that poor motivation is another symptom associated with apathy that was related to atrophy in that orbital frontal cortex. Again, you remember that area is important for determining information regarding interpretation of reward. And so we believe that apathy occurs when people lack the ability to be motivated by positive reward, like praise from a spouse or a caregiver, or even negative signals like, scowling at your loved one. So then the question becomes, are these symptoms perhaps amenable to different treatments? So now with like a more refined knowledge of why apathy occurs, we can think about how we can target each underlying mechanism, each symptom. And here are a few examples. So for people with initiation difficulty, it may be improved by something called external sensory cueing. And there's some evidence for this in Parkinson's disease, where patients can have lots of difficulty with initiation, with just getting going. And so external sensory cues are externally initiated prompts, like auditory prompting or visual stimulation, to get the patient going on an activity. In the same regard, enhancing the sensory signal by using multisensory stimulation may also be useful to activate a person with apathy. Multisensory stimulation is sometimes used in nursing home settings, in a room where sensory stimulation can be controlled. They do things like blow bubbles, touch Play-Doh, finger paint to encourage engagement at the same time that they are playing music. For people who have planning difficulty and they may already be disorganized, that additional noise may actually worsen their apathy, or may even cause them to be a little bit agitated. So for people with planning impairment who have difficulty with the mental manipulation of an activity, it's important to think about their cognitive limitations and to prescribe their activities that are based on their strengths. And people like speech and language pathologists, occupational therapists, physical therapists, recreational therapists are really great resources for this. Individuals who are disorganized and have planning problems may need to be in a more structured environment where choices are constrained, maybe one or maybe two choices, and activities are done in a straightforward manner in a step-by-step fashion with frequent cueing. For individuals where we need to target motivation, it's important to think about what types of activities are rewarding for the person with FTD, and use rewards to engage people with FTD. For example, people with FTD, gum is often a good motivator. And lastly, interventions like music therapy, especially live and interactive music, physical activity, have been shown to improve apathy across these different symptoms. So with generous funding support from the AFTD, we developed and tested an app, a mobile app called ActiviDaily, which takes the strategies that I just described and incorporates these strategies into a mobile health application with the goal of helping people with FTD with apathy to engage in more activities. And so in the next couple of slides, I'm going to briefly talk about how we operationalize these strategies within the app to target problems with initiation, planning, and motivation. So to target initiation, we used alerting mechanisms like reminders, suggested activities, or nudges, and push notifications, which were programmed to help the person initiate behavior. We worked with caregivers to set attainable goals for the person with FTD. And once the goals were set, we used calendars and we used checklists, and we simplified the activities in a step-by-step fashion, thereby creating a specific plan to attain the goal. As patients move towards their goals and they fill up their progress bar, it says 100% here, they receive rewards in the form of coins. And they can spend the coins on things that are motivating for them, such as music and games, which are implemented in the game store of the app. So now I want to turn to managing poor impulse control. How do we manage impulsivity? First, consider maintaining a behavioral log so that you can identify any patterns or potential triggers. Crowds are often a trigger and can oftentimes induce impulsive behaviors. So we tell our families to go to places off hours when places aren't so busy. For example, instead of going to a restaurant during peak hours, you may want to visit when it's less crowded. Providing a card to servers or to staff to let the people that are interacting with the person with FTD know that their behavior is due to their disease. And I believe that there is a template for this card on the AFTD website. Individuals with FTD are easily distracted, and sometimes you can use this in your favor. So if the person with FTD begins to perseverate on a topic, try redirecting their attention elsewhere. For individuals who are hyperoral and eat large quantities of food or eat quickly, you want to try to control the amount of food that is in front of them by putting smaller portions on the plate. And lastly, and I know this is easier said than done, but try not to reason with the person with FTD. Oftentimes there's little insight, there's little self-awareness, so trying to reason with the person with FTD just often leads to more frustration. Here are some general strategies for managing behavior. People with cognitive impairment benefit from a regular routine that is predictable. This includes a schedule of activities that can keep the person with FTD engaged throughout the day. And again, oftentimes therapists can come and can help the family to develop the curriculum of activities that is appropriate cognitively and functionally for the person with FTD. Adult day programs, I realize that many of them aren't in session currently, but adult day programs is another way to do this. And then again, remembering that the behaviors are not about opposition, that the behavior is a direct result of the disease that's in the brain. So to conclude, we see that behavioral symptoms emerge when there is damage to the frontal and the temporal lobes of the brain. And when we understand what's happening at the anatomic level in the brain, we can use this information to inform our treatments. And I talked about this in some of the work that we're doing with apathy, but I hope that we can also look at other behavioral symptoms in FTD the same way by really understanding the brain mechanisms behind the behavior with the goal of individualizing our therapies. And so I want to acknowledge the generous funding support that I received from the National Institutes of Health and the Association for Frontotemporal Degeneration. I'd also like to acknowledge the incredible group of people that I'm so fortunate to work with in the Penn FTD Center who are dedicated to studying FTD disorders. Finally, I have the great privilege of caring for people affected with FTD, and I've been able to witness the unconditional love and the commitment of the caregivers who I've learned so much from. And so I want to thank those patients and their caregivers who have shared their FTD journey with me, who have really made me into the clinician and the researcher that I am today. So with that, I thank you for your time and your attention.
Well, thank you so much, Dr. Massimo, for your valuable insights. That was a fascinating presentation. We'll now take questions from the audience. Again, please use your question box to type your answers, to type your questions, and we will answer as many as time permits. If there are questions we can't answer, we'll try and get back to you after the program with an answer. Well, let's see. First off, someone had a question about who is a good candidate for the ActiviDaily app. My wife, who had semantic PPA, lost her ability to use electronic devices early in her progression.
Yeah, that's a great question. So the ActiviDaily app, we just completed, I'll tell you where we are with the ActiviDaily app, which again, we're so thankful to the AFTD for supporting the development and then the testing of the app in a pilot study. And what a pilot study means is that it is done to test the feasibility and to look for some preliminary evidence that's going to benefit our participants. We initially tested the ActiviDaily app in individuals with behavioral variant FTD who had mild disease, because again, we wanted just to test the feasibility of the app. And the good news from that is that it does appear to help those individuals with behavioral variant FTD increase their daily activities. We also saw with use of the app, we tested it for 4 weeks, that it also helped to reduce the burden on caregivers, right? Because caregivers are often having to, repeatedly ask an individual with FTD to take a shower, to brush their teeth, to get dressed. And so the app, I call it like the nudge, was able to nudge the participants with bvFTD. So, they were able to increase their activities. We were able to help out the caregivers. Regarding the individuals with primary progressive aphasia, or even the individuals that we think of with motor difficulties that may have problems with using the app, now that we've completed our pilot study, we're in a phase of revising the app. So it's adding features like a voice to text option and having an Alexa-like feature that can interact with the user. We also developed the app. We had to develop it on a certain platform. And so now we are getting ready to launch the app to be able to be used on iPhones or other mobile products. What's happening was, we were giving the participants in our study a phone, and they were unfamiliar with the phone. And so again, we think that the familiarity with like an iPhone will be helpful as well. So while we did test this in individuals with behavioral FTD, we certainly are thinking about the other FTD phenotypes and how we can accommodate the impairments like language impairments, speech impairments, motor impairments, so that we can eventually extend the app for other FTD phenotypes.
Well, that's exciting. That's excellent to hear. And definitely looking forward to hearing more about that as that work progresses. So here's another question that has to do with phenotypes. Is my loved one is diagnosed with primary progressive aphasia, but also has many of the behavioral symptoms you described. Does that mean he has both behavioral variant FTD as well as PPA? Can they have both at the same time?
Yeah, that's another good question. So so individuals with, let's take semantic variant primary progressive aphasia, for example, they may start off with speech and language difficulty, like difficulty understanding the meaning of words, difficulty finding the words. It's all not uncommon for those individuals because, again, remember, their temporal lobes are affected. And I pointed out in the presentation that the temporal lobe is responsible for some of the behaviors that we see. So it is common for individuals with semantic variant primary progressive aphasia and even the non-fluent variant primary progressive aphasia to have even subtle behavioral changes. And what we typically see is that over the course of their disease, as their disease progresses, it progresses more into the temporal lobes, perhaps progressing into the frontal lobes, that these individuals do in fact develop behavioral symptoms. In our center, if they meet the behavioral variant FTD criteria that I outlined, then we will give them a kind of secondary phenotype of bvFTD along with their semantic variant primary progressive aphasia.
As if it wasn't confusing enough to begin with.
That's why we have criteria like the bvFTD criteria that try to keep us researchers and clinicians honest and really all talking the same language. I mean, this is international criteria that we're using.
So since the symptoms and behaviors do change over time, how much predictability is there? Is there any work being done on trying to map out courses of the disease?
Yeah, there are incredible efforts, as you know, that are being made to follow people longitudinally, to follow people over time, to follow people from even individuals that we know have inherited mutations where they are asymptomatic or pre-symptomatic, and follow them over the course of their disease to understand how disease begins and how it spreads and how the brain responds to different behaviors that we see. There have been a few longitudinal studies that have been performed to evaluate this really important question. How do the behaviors change over time, right? Caregivers want to know what to expect. And again, the caveat is that everyone's trajectory is very different. But there was a nice paper published by the Australian group in about 2016 that showed that people with FTD, particularly bvFTD, showed a reduction in their disinhibited behaviors and their stereotype behaviors over time as their disease progressed, while their apathy increased. And there was also an increase in the number of their abnormal eating behaviors. So again, it seems that, you know, in bvFTD, that individuals that start off pretty disinhibited will become less disinhibited over time, but that's replaced by an increase in apathy and oftentimes changes in eating. I should also say that, you know, apathy, you know, while I chose to focus my work on apathy, because it's a really serious symptom and it needs to be paid attention to. In the emerging literature suggests that apathy is associated with an accelerated rate of functional decline, right? Because people are just kind of sitting around and doing nothing. So it accelerates their functional decline. And in some studies, apathy has been also related to an increase in mortality. So, you know, again, it's this very significant neuropsychiatric symptom that really needs to be paid attention to.
Excellent. All right. This is sort of on a different topic, but we had a question about how some neurologists and researchers do not think of the brain as being highly organized and able to pinpoint a specific region to a specific function. What are your thoughts on this?
Yeah, I would agree with that. I mean, that was one of the caveats that I laid out in the, you know, in one of the first slides, is that the brain is, you know, there are networks in the brain and different regions talk to one another. So again, it is, while these studies, you know, we try our best to make certain assumptions about particular parts of the brain that may be associated with particular functions, but, you know, in fact, the brain is a network of regions and structures, and they all talk to one another. So, you know, I would agree with that. But, you know, again, I think that the studies that I outlined, you know, are certainly important in kind of offering an understanding of structures, what we know the structures do, and when these structures fail or associated structures fail, what the behavior looks like.
So I've heard people with FTD say that they can have good days and bad days, and it sounds like this may be related, but do you know how this happens, and is it related to like how well the intact parts of the brain are functioning?
I mean, that's a hard question to ask. I mean, there's so much variability. I mean, I hear the same thing, you know, there's good days and bad days. You know, I think that I tend to think of the brain of an individual with any form of cognitive impairment as a vulnerable brain, right? You have a vulnerability in your brain, you have disease in your brain. And so as a nurse, I think about the environment and what the, you know, environment, you know, is doing to the brain and how that brain is responding. So for example, if the individual with FTD is used to being in some kind of routine and then they're taken out of the routine, they have a bad day. If the individual with FTD, if they are in an environment that is noisy, is busy, they may be distracted, and that may cause them to have a bad day. If they don't sleep well the night before, that could cause them to have a bad day. So, you know, again, I think that I don't think that there's any one answer. You know, I think that it's likely multifactorial.
Mm-hmm. And a good reminder that it's not always just what's happening inside the brain, but everything around the brain is just as important in many ways.
Exactly, yeah. Mm-hmm.
So there's a question about dysphagia, and how does that dysphagia figure into brain anatomy, and how does it relate to PPA? And I guess let's start with this, what dysphagia is.
Yeah, so dysphagia or difficulty swallowing. We often see this in individuals with PPA. We often see this again as the disease advances. And so again, we know that the disease doesn't just stay in one part of the brain, that over time that the disease will spread in the brain. And so the difficulties swallowing can emerge in, you know, in a couple ways in individuals, and even people with behavioral variant FTD. We can, again, they're not excluded from having the complications of difficulty swallowing, especially in the later stages of the disease. So people will often develop problems where they may cough after they drink some fluid. That can sometimes be a sign that there's problem with swallowing. They may pocket food. They may clear their throat after they're done swallowing something. And so again, that's not uncommon in the later stages of the disease. In people with progressive supranuclear palsy or some of the motor symptoms or motor diseases, certainly people with ALS or Lou Gehrig's disease. As you know, people with FTD, some individuals can also have ALS. That difficulty swallowing tends to happen early on in the disease and is associated with the motor parts of the brain.
Okay, so it's not just one thing, there's several different possible causes. What's the best, if there are concerns about swallowing, who do you, is that something you would take care of, or who would you go see about that?
Yeah, so speech and language pathologists are a great resource for individuals who are having difficulty swallowing, right? And so they can evaluate the person who's having the swallowing difficulty to see what's the best texture for the individual to swallow. They can also help work with the family to develop a plan of care and different strategies to help the individual swallow. So, you know, again, using thickener, sitting the person, you know, in an upright position when you're eating, and not kind of like, you know, slumped over, but sitting in an upright position with your, you know, with your chin in a certain position, limiting distractions around, you know, the table when you're eating, right? Like, so that somebody's not eating, gets distracted, looks over here, and then has difficulty swallowing. I mean, we see that in people with, you know, with FTD. Again, those hyperoral individuals can also have not as difficulty swallowing, but, you know, if they're shoveling food into their mouth, the food can, you know, or the drink can certainly go down into the wrong pipe, and that can sometimes cause a problem called an aspiration pneumonia. And so, so I would say if somebody is having difficulty swallowing, certainly this is something that you want to discuss with your clinician. Oftentimes the clinicians will then refer to or consult with a speech and language pathologist.
Excellent, thank you. So we had a question about the difference, or how to tell between mental health diagnoses and FTD and what the relationship is. And someone was asking if a person had obsessive compulsive disorder before a diagnosis, will it get worse as the disease progresses? And is there any way to stop any of their obsessions?
Yeah, so the first part of that question that I think I want to just acknowledge is the particularly frustrating experience for caregivers of individuals with FTD with just getting a diagnosis, right? I mean, we know that individuals with FTD are bounced around from doctor to doctor before a proper diagnosis is made for many, many, many years, and is extremely frustrating. In terms of if someone had some mild obsessive compulsive disorder and mild obsessive compulsive problems, will that get worse? It's hard to say. The behaviors for the obsessive compulsive disorder might manifest differently. So again, say individuals with obsessive compulsive disorders may often feel the need to wash their hands lots of times, or maybe they check on the doors. And you can see those behaviors in individuals with FTD, but perhaps now those individuals, the compulsive behavior might be more ritualistic behavior, right? That we see where someone has to visit a certain restaurant at a certain time every day and eat a certain, a certain food. There may be like a certain pattern that they need to walk the house before they do, a particular activity. So, we can see these more complex ritualistic behaviors. And then we can also see these kind of simple repetitive behaviors that, that are extremely difficult to deal with, right? So humming the same tune over and over again, or, tapping your fingers, slapping your hands, rubbing your legs, those types of simple repetitive behaviors that we don't often see in individuals with obsessive compulsive disorder. So again, it's the symptomatology that differs from obsessive compulsive disorder. Presumably the obsessive compulsive disorder that someone had premorbid or prior to their diagnosis would hopefully respond to, to medications. And so in FTD, we use a lot of those same medications. I'm not going to name any in specifically, but we use a lot of those same types of medications to help control these types of compulsive ritualistic behaviors in individuals with FTD.
Okay. So it looks like we probably have some time for 2 or 3 more questions. So here's a question about what about when there are very specific areas of impulse problems, such as financial, yet combined with normal functionality in other areas of the life?
So when there's like impulsive buying or spending and a preservation of functional status.
Right. Otherwise, yeah, people are able to function pretty normally.
Yeah, so that is often the frustrating, another frustrating experience for FTD caregivers, that people with FTD may look and may appear well. They may appear normal. Their memory is good. If they don't have aphasia, their speech and language, may be unaffected. And so, oftentimes we see people with FTD making poor financial decisions, again, because of the impulse problems, because of their executive problems, right? They're not able to organize their financial situations. They become heavily disorganized. And so, oftentimes in those types of situations, if you have a diagnosis of FTD, sometimes, it is a matter of, you want to protect your finances, so of getting a lawyer involved. Other times to kind of help manage that the spending problem. Some caregivers that I know will give their loved one who's diagnosed with FTD, a debit card with just a specific amount of money on their card that, they can't tap into too much money. And it's really about supervising the spending, as much as possible. It's difficult.
Yeah, for sure, and can cause so many other problems.
Yeah, and this is also, again, where you want to, it's so important to talk about these real life issues with your clinician. It's so important to do that.
Yeah, because oftentimes people have a hard time just finding a lawyer. So it's always a good
Right.
idea to ask around. And, I'm sure you've encountered people in a whole array of different professions that can help. So
And the AFTD has some good resources for that as well. I know that the AFTD just did a webinar not too long ago on legal issues. So that might be a good webinar to check out.
Yes, absolutely.
Here's your plug for the AFTD.
So we have a question about the difference between apathy and depression. And this person's husband started with severe apathy, but was diagnosed with depression by several different clinicians. So what are the difference between apathy and depression? And is there any way that caregivers in particular can tell doctors that would help them make that distinction so people don't have to go down these roads that ultimately aren't very helpful?
Yeah, so again, a great question. And again, I'll point out the experience of the FTD caregivers that their loved ones diagnosed, it's apathy. Their loved one has FTD and it's apathy, and they're diagnosed with depression over and over and over again by their primary care provider and other clinicians, and they get bounced around. And finally, they come to, a diagnosis of frontotemporal degeneration, where apathy is very common, depression is less common. It's really hard to distinguish between apathy and depression because they share some features like low social engagement. People just, kind of look like they don't care. There's loss of motivation. There's a flat affect in both apathy and in depression. But in people who are depressed, they often feel sad. It can be accompanied by feelings of anxiety and guilt. And we don't see a lot of that in FTD. We don't see a lot of depression, apathy. We don't see, because it could have to do with the level of awareness, right? Level of insight that somebody has. People with FTD, again, may not fully understand that they have a devastating disease that's progressive in nature, and it's probably also, again, related to neuroanatomy as well. Another thing, is that, again, I'm speaking very generally here because individuals with some forms of FTD do have depression, but again, so I don't want to discount that that's impossible because we do see that, but really that feeling of dysphoria, of sadness that you see in depression, that you see less often in people with apathy.
Right. So,
and while the caregiver can ask their loved one whether they're feeling sad or whether they're feeling down or depressed, you can use those kinds of words. Again, this really takes a skilled clinician to be able to differentiate, apathy and depression.
There's a question about, you showed many MRI images, but did not mention PET scans. Is PET still considered a more accurate tool for diagnosing FTD?
I don't know that it's more accurate, but it's helpful. It's a helpful tool. So PET looks at at brain function through a variety of ways. And so oftentimes, if we look at an MRI and we're not seeing these really discernible patterns of atrophy, but someone has a history where it sounds like FTD, the cognitive exam looks like it's FTD, but their MRI is unremarkable, or if their MRI, there's kind of subtle hints of atrophy on the MRI, then we will use PET scans to be able to help us to look for other evidence of hypoperfusion in certain areas of the brain. So I would say that it's also a helpful tool in addition to the MRI.
Mm-hmm. So it sounds like in some cases a PET scan may be able to detect changes in the brain that it's too early, I guess, or too soon for them to show up on an MRI.
Right, exactly, yeah. So sometimes, again, early on in the disease, there may not be any kind of slam dunk on the MRI where you say, oh, this is definitely FTD, look at this atrophy. Again, and if that's the case, getting a PET scan and looking at, taking into account the whole picture, right? We don't ever just diagnose someone on the MRI or the PET scan. We diagnose people based on their history and on their cognitive exam, on their MRI, sometimes on the PET scan. Here in the epicenter, we also look at cerebral spinal fluid. So we really do kind of look at the whole picture.
Thank you. No, that's an important reminder that, there's not like there's any magic bullet or tool that can do this on its own. It's very complex.
Yeah.
So let's see. You mentioned spinal fluid. Is there any ways now that people, or what's the easiest way available now to tell the difference between Alzheimer's and FTD?
The easiest way available?
or are there ways available that
are there ways? Yeah. So there are ways that can help us to be more confident in our diagnosis, right? So again, always taking a really good history, the cognitive exam, the MRI, right? You can see different patterns in people who have Alzheimer's disease pathology versus FTD pathology. PET scan. So I talked about the PET scans that look at like glucose metabolism, for example. But there are also now PET scans that tag amyloid in the brain, which is common in people who have Alzheimer's disease. And there's also tau PET scans. We at an FTD center do collect cerebral spinal fluid, and we look at the levels of those proteins that I just referred to, amyloid and tau, that we know cause these conditions, to be able to help us to discern who likely has underlying Alzheimer's disease pathology or who likely has underlying FTD pathology. So again, it really is looking at taking multiple tools that we have at our hand and really kind of putting the picture together to be able to arrive at a diagnosis.
Well, again, thanks for all your time today. I think that's about all the time we have for questions. And like I said, if we didn't get to your question, we will try and get back to everybody with an answer. But thank you so much, Dr. Massimo, for being with us today.
Thank you so much for having me.
All right, take care. Well, we hope you found this presentation to be informative. We will post the recorded webinar on AFTD's website under the news and events and send out the link as soon as it is available. Again, thank you for. Let us know if you have any comments or questions about today's presentation or about other ways AFTD can assist you moving forward. And be sure to visit our website and make use of AFTD's helpline if you need to. So goodbye until next time.